Thank you, Mr. Chairman, and a very good morning, but cold morning, ladies and gentlemen. Now, stroke, something which we all fear, is a major cause of disability and death, and I don't know whether which is worse, disability or death. Yeah? But the basic treatment approach is one, to quickly restore blood to the focal area, for example, sterilizing the arterial thrombus. And today we have pharmacology agents like alteplase that can, which is thrombolytic and can sort of dissolve the arterial thrombus. And of course, secondly, to prevent and minimize injury to the brain tissues, and this through using a neuroprotectant. Now, although a pharmacology agent is already available for the first approach, but very unfortunately, today, we still have no clinically proven neuroprotectant. Now, more than 1,000 compounds have been shown to be neuroprotective in cell and animal studies, but none actually succeeded in human trials. And various compounds from various pharmacological groups have been tested. They include the MNDA antagonist, calcium antagonist, sodium and potassium channel blockers, glycine and serotonin receptor antagonists, antioxidants and radical scavengers, GABA receptor agonists, anti-inflammatory agents, etc., etc. Now, many of these have shown to significantly reduce infarct volume in animal models, but unfortunately disappointing when performed in human trials. Now, there are various reasons for this failure. Firstly, the brains of animals are actually different from that of humans. That's why we can think better, we can act better. For example, rodents has only about 10% of white matter, whereas humans, we have about 50%. And therefore, rodent studies basically display protection on the gray matter. An agent may not necessarily be also active against the white matter. And as we know, white matter is a major component affected in human stroke. For example, if a disruption of the white matter, which are like cables, electrical cables, then you have disruption of motor and sensory function. Therefore, today, the new paradigm in the search for neuroprotectants, they must both protect not only the gray, but also the white matter. And other reasons for failure. Many studies have been using excessive doses in animals, and therefore they are not translatable to humans. And secondly, in many cell-based studies, unrealistically high concentration have been used. For example, if you look at the slide, look at the diagram below, this is a study that we have conducted to look at the distribution of the tocotrienols in various tissues and organs at a human equivalent dose of about 600 milligrams. And you can see that although the tocotrienols are well distributed to most of the tissues, but yet the concentrations are relatively low. And max, you can see, is about 5 microgram per ml. That's only for the alpha tocotrienol, which is the form that's better absorbed as compared to the other two forms, like the gamma and the delta tocotrienol. And therefore, if you do a cell-based studies and use concentrations that are excessively high, you can never get this kind of concentrations in a human body, and therefore, it will not be translated to some human benefits. Now, another major reason for failure is that many of these compounds, so-called neuroprotectants, were evaluated for acute treatment of ischemic stroke. And as we know, stroke has a short treatment time window of approximately 4.5 hours. And also, during an ischemic stroke, the blood flow to the focal area is already limited. And therefore, even if you administer a neuroprotectant at this stage, it may not reach sufficient concentration at the focal area. And therefore, ischemic stroke is really not a good model for studying all these neuroprotectants. An agent should best be given before and not after a stroke event, like they do in most animal studies. Therefore, prophylaxis may be a better strategy, especially for high-risk populations. For example, those with atrial fibrillation, those with TIA, or those undergoing angioplasty or coronary bypass, or even those with high cardiovascular risk factors. Now, antiplatelets, anticoagulants have been commonly used for this purpose, But for long-term neuroprotection, as I mentioned earlier, today we have no pharmacological agent available. But having said that, I think vitamin E, tocotrienols may have the potential. Now, just a quick background of vitamin E. Vitamin E was first discovered in 1922, and today we know that if you have vitamin E deficiency, you will have loss of fertility, muscular dystrophy, encephalomalacia, and also neurological abnormalities manifested as areflexia and ataxia. And therefore, we know today vitamin E is actually essential for the normal health and function of our nervous system. Vitamin E actually consists of 8 isoforms, 4 tocotrienols and 4 tocopherols, and they both share a common structural features of a chromonal head and a vital side chain. Now, the difference between the two series lies in the side chain, whereas the tocopherols have a fully saturated side chain. The tocotrienols have 3 double bonds at the 3, 7, and 11 positions of the side chain. And they are designated as alpha, beta, gamma, or delta, depending on the number of methyl groups on the chromonal head. Now, if you compare tocotrienols versus tocopherols, a scan of the literature will reveal that the tocotrienols have some unique biological activities not observed with tocopherols. And a notable example, as elaborated by the previous speaker, is that alpha tocotrienol, but not alpha tocopherol, and nanomolar concentrations, these extremely low concentrations, shown to protect neurons from degenerating when challenged with glutamate. And the mechanism is not through its antioxidant properties, but rather through modulating chemical signals within the neuronal cells. And later studies in rodents, and also dogs more recently, have shown that the tocotrienols have protective effects against stroke-induced neurodegeneration. But the ultimate proof of the genuine worth is still evidence from human studies, and that forms the basis of the study that I'm going to present. But before that, from our own animal studies, we also found that, first, the tocotrienols can reach your brain. Although it's lower than the other tissues and organs, but it can still reach your brain, in particular the alpha tocotrienol. Now, we also have conducted our own studies in humans, and we found that the half-life of the tocotrienols actually is very much shorter than that of the alpha tocopherol. For alpha tocopherol, the normal half-life, biological half-life in humans is more than 20 hours, whereas for the tocotrienols, as you can see here, for alpha tocotrienol is in about 4.5 hours. Likewise for gamma tocotrienol, and even shorter for delta tocotrienol. And therefore, a twice daily dosing is really recommended. Now, we started this study about almost 4 to 5 years ago, and it's a collaborative effort among scientists from the University of Sains Malaysia, the Malaysian Palm Oil Board, and also Hovid Berhad. And the study is actually funded with a grant from MPOB. Now, our biggest challenge, actually, at the time was to find a suitable human model. Because if you use the wrong model, you will get the negative results. And then we will add the tocotrienols to the list of failed compounds. So that was our dilemma, our biggest challenge. And then if we fail, all those earlier good work, all those beautiful mechanisms by my good friend Chandan Sen will all gone to waste. And all this will remain just a publication and soon be forgotten. And a suitable human model should have the following attributes. Firstly, it must involve lesions of the brain, of course. Must be quantifiable, non-invasively, example, using MRI. Must be self-progressive, so that not like the animals, we don't have to induce. And also permits the agent to be evaluated prophylactically. That means as a long-term preventive. And we will scan the literature, looking at all these various brain conditions. White matter lesions seems to fit the bill. Now, what are white matter lesions? Many older people, including myself and many of you here, if you go for an MRI, you may have hyperintensity in your images, your brain MRI images, even though you have no apparent symptoms. And these are actually lesions formed from bundles of nerve fibers degenerating due to small blood vessel disease of the brain. And development actually increases with age and presence of cardiovascular risk factors. And deterioration of lesions or infarcts is self-progressive. Okay. And therefore, it can be utilized for the prophylactic studies of neuroprotectants. Now, these are some of the sample images that we obtained from our volunteers. If you can look at the top panel here, they are all clear, they have no lesions. Whereas those at the bottom, you can see very clearly they have all these white matter lesions in the brain. So what are the measurable outcomes in our study? Will be the volume of lesions on repeated MRI. Now, if tocotrienols are indeed neuroprotective, so what would we expect? We would expect lesser increase or progression in the volume of the lesions compared to the placebo. In our study, we recruited 121 volunteers with white matter lesion. They're all above 40 years and with one or more of the following, either the BMI more than 25, or they're hypertensive but under therapy, or they're diabetic but under treatment, or they're hypercholesterolemic. We randomized them to receive 200 milligrams of tocotrienol, basically Tocovit Superbio, twice a day, or placebo. Then we MRI them at baseline, repeated 1 year and 2 years. We also recruited another 120 volunteers with no white matter lesions, but they're all with the risk factors, like hypertensive, BMI more than 25, they're diabetic or hypercholesterolemic. And then this group also randomized to receive 200 milligrams of mixed tocotrienols twice daily, or placebo. And we MRI them at baseline and also repeated 1 year later. Now, both studies were double-blind and placebo-controlled. We are fortunate that we have a MRI machine equipment in our university, which we can use for free. Now, the volume of the lesions from the MRI images were quantified using a validated Endeavour software. Basically, it's a software where we just plug the MRI file into the software, and the software will then create a 3D image of the brain, identifies the white matter lesions, and then compute the volume. This is an example of the file that we plug into the software for year 208, and year 209, and year 2010, and then from there, they then compute the volume of the lesions. Now, what are our findings? For the MRI negative group, that means the group that did not have white matter lesions, but with the risk factors, 113 out of 120 completed the study. 52 were on placebo, and of the 52, 17% of them developed white matter lesions after 1 year. 61 were on tocotrienols, and 31% developed white matter lesions after 1 year. So on the first look, this seems very good, isn't it? Because more on the tocotrienol group actually developed white matter lesions. But it was not significant. However, if you compare the volume of the lesions in the placebo group versus those on tocotrienols, then you see a different picture. As you can see here, this is the mean volume of those on placebo versus those on tocotrienols. As you can see, there's a more than 4-fold difference in terms of lesions, and this actually is comparable to those from the animal studies. For example, the study in rats, you can see the difference within the tocotrienol group and the placebo group, and also the more recent study by Ring et al. In dogs. You can see the big difference between the group on tocotrienols and the group on placebo. Now, for the MRI positive group, that means those already presented with white matter lesions, we managed to recruit 121, and of which 62 were on tocotrienols and 59 on placebo. 109 completed 1 year, and 88 completed 2 years. So we lost a few volunteers, which is very common in most clinical trials where you have to follow them for such a long period, over 2 years. And the data were analyzed according to per protocol, where we used 88 who actually completed the study and adhered to the protocol, and also intention to treat principle, where we used all 121. Now, these slides will show you the mean lesion volume of the volunteers on placebo and on tocotrienol. As you can see here, those on placebo, you can see a progression from baseline after 1 year and 2 years. Whereas those on tocotrienol, you can see there's negligible change in terms of the mean volume over 2 years period. And if you calculate the change in the volume, after 1 year, you can see the placebo group, there's a big increase in the mean volume of the lesions, whereas there was negligible change for those on tocotrienol. And at 2 years, you can see again that those on placebo, the mean lesion volume continued to grow bigger, whereas again, negligible change for those on tocotrienol. Now, for the intention to treat principle, we also got almost identical results. For those on placebo, we can see an increase in the mean volume of the lesions, whereas those on tocotrienol was negligible change over 2 year period. And again, the volume change was negligible for this on tocotrienol, and you can see a marked increase in the volume of the lesions of those on the placebo. So actually, in summary, both studies actually provided objective evidence that the tocotrienols are neuroprotective in humans, particularly to the white matter region. And previous animal studies already proven that the tocotrienols will be protective against in the gray matter, and therefore, taken together, tocotrienols may help to minimize the extent of tissue injury in the brain during a stroke event, and hence the clinical outcome. And tocotrienols are not drugs per se. They're just natural vitamin E isoforms, and therefore safe to be taken as a long-term neuroprotective supplement. But just a point to note, like all fat-soluble vitamins, the oral bioavailability of the tocotrienols is poor and erratic, and hence their usefulness can be limited by their absorption. Now, this is a study that we carry out in rats to look at the absolute bioavailability. And therefore, we just compare the oral versus IV. As you can see here, for alpha tocotrienol, the absolute bioavailability is about 30%, and it's much lower for gamma and delta tocotrienol, which is less than 10%. And if you work in the formulation area, then you know that if that's the case, then you can actually tweak the bioavailability by using a special delivery system. And this system was then applied to Tocovit SupraBio. As you can compare the Tocovit SupraBio versus the normal soft gel formulation, you can see that the absorption or the bioavailability of the tocotrienols was increased by approximately 3-fold compared to the normal soft gel formulation of the tocotrienols. And this is not only true for the alpha tocotrienol, also true for gamma tocotrienol, and also for delta tocotrienol. And the significance of using such a system is really borne out by 2 separate human studies of tocotrienol on arterial compliance conducted by a group in Malaysia, in the eastern state of Kelantan. Now, both studies were placebo-controlled, involving 36 human volunteers, one study using the normal tocotrienol formulation, the other using the bioenhanced system. Whereas no significant effect was observed with the normal soft gel formulation, a significant improvement was observed with Tocovit SupraBio, although the doses used were much lower. Now, with the impressive results that we have just obtained with the study on using the white matter lesion, now we are actually conducting another study, this time looking at the effects of the tocotrienol supplementation on peripheral neuropathy and cognitive dysfunction in type 1 and type 2 diabetic patients. And this study is also funded with a grant from Pemandu, the Malaysian government. And it's a study that is conducted in collaboration with the Clinical Research Center of the Seberang Jaya Hospital, where the co-principal investigator is actually a neurologist, Dr. Irene Lui. We have started recruitment of patients since December 2011, and to date we have recruited about 200 patients now on this trial, and our target is 300. Hopefully by the end of the study, I have new data to present to all of you. And we also have just planned another study, this time looking at the effects of tocotrienols on rehabilitation outcomes in post-moderate stroke patients. And we've just submitted our proposal to the ethics committee last week. And hopefully these trials will provide more clinical evidence on the usefulness of the tocotrienols as a neuroprotective supplement. Now, finally, ladies and gentlemen, this is the MRI of my brain. Yeah? It looks something like that of Einstein, I hope. Yeah? Now, although you can see that I do not have any white matter lesions, quite clear, but I do have a lesion here. Actually, while performing the study on the white matter, using the volunteers of white matter lesion, I had a stroke. Yeah. And today, I'm diligently taking 200 to 400 milligram tocotrienol daily. Okay. And I think while doing this study, I was actually on 50 milligram of tocotrienol. Yeah. So perhaps this could have sort of prevented the lesions from growing bigger. Now, these are my other team members. Professor Ibrahim Lufti is a senior consultant radiologist at the Institute of Advanced Medical and Dental Sciences. Dr. Nuzalina, Dr. Enrico is here, and these are all the other collaborators. Dr. Leong is an interventional radiologist. From MPOC, we have Dr. Sundram, and from Howitt, we have Dr. Wong and Dr. Ng. Now, I must also acknowledge the assistance from my other postgraduate students, because to run the study of so many volunteers over a 2-year period can be very time-consuming and involve a lot of efforts to make sure that we don't lose the volunteers, etc. With that, ladies and gentlemen, thank you very much for your kind attention.
Thank you, Professor Yuen.